Dr. Appiah,
if you're ready. Thank you for joining Colorado Fertility Advocates for our webinar called I Thought We Fixed That on insurance coverage for fertility care in Colorado, where we'll be addressing the current situation of the law and ability for patients for fertility diagnosis, treatment, and preservation to have insurance covered under the law and otherwise be able to afford and have access to that type of care. We are recording, so if anyone's unable to see the whole video of this or to watch the entire time, you will be able to access it on the Colorado Fertility Advocates website. We do have a couple exciting announcements we want to preview, so I'm going to pass it over to my colleague helping organize this webinar, Judith Hates, who will be sharing a few of those announcements. Judith, would you like to share those now?
Yes, thanks, Ellen. As many of you know, today, Resolve is the National Infertility Association, and April 25th of this year is Resolve's virtual Federal Advocacy Day, which is an interactive online event hosted in partnership with the American Society of Reproductive Medicine, where the infertility community comes together to talk to members of Congress about important issues like increasing access to family building options and financial relief. Please sign up for this amazing opportunity to talk to members of Congress, to share your stories and advocate for fertility coverage. My second brief announcement is that on the evening before, on April 24th, CFA members are invited to share in a first-time event, a special reception at the Slate Hotel in the heart of the Civic Center in downtown Denver, and then we'll walk 3 blocks to witness the lighting up of the city and county building directly across from our beautiful Capitol in orange, as it will be done in some other cities across the country. The lighting will take place at sundown at about 7:30 to 7:45 p.m. And you'll find information on CFA's website about both Advocacy Day and this very special event. And Ellen, I'm turning it back to you. Thank you.
Thank you. And special shout out to Gina Horton, who did a lot of work on getting the county building, city and county building lit up in orange. That'll be very exciting and special. Now I'd like to introduce the chair of Colorado Fertility Advocates, Dr. Cassandra Roca. Cassie is a board certified obstetrics and gynecology, as well as reproductive endocrinology and infertility, working with patients at Shady Grove Fertility. Cassie currently chairs Colorado Fertility Advocates and is our brave leader this year. And she may be frozen. Oh no.
Okay. Thanks so much, Ellen. Hi, everyone. I'm Cassie, and I am the current chair of Colorado Fertility Advocates. Thank you so much to Ellen and Judith for putting together this extremely important panel. As many of you probably know, Colorado Fertility Advocates was integral in not only writing the bill, but passing the Colorado Building Families Act, as well as the Fix-It bill for implementation, which went into effect as of January 1st. And as a physician, in Colorado, I've seen this benefit a lot of patients, but I think people still have a lot of questions. And so we have, very esteemed panel today to help inform what does this bill mean? What benefits do we see in Colorado that weren't before? And what more work do we have left to do? And so I'm really excited to hear what everyone has to say. And thanks so much for everyone who's here.
Okay, a couple brief introductions of our moderator and our panelists, and then we'll get to the bulk of what we're here to talk about. So first, I'm honored to introduce our moderator, Trish Zornio. So Trish is a scientist, lecturer, and journalist who has worked at some of the nation's top universities and hospitals. Trish developed a keen interest in access to fertility care issues in Colorado after witnessing the obstacle faced by a close friend in her fertility journey. We're also joined by Betsy Campbell, who's a panelist on our webinar today. Betsy is the Chief Engagement Officer for Resolve, the National Infertility Association. Betsy works to empower constituents, including Resolve's community of over 800 volunteers, to make a difference through volunteering and advocacy. Betsy and Resolve work closely with CFA on the Colorado Building Families Act. So you'll hear lots of the history from her. Dr. Leslia Appiah is also on our panel. Thank you, Doctor. Leslie is a professor and division chief of academic specialists in obstetrics and gynecology at UC Health. with specialties in pediatric and adolescent gynecology, fertility preservation, and reproductive late effects in cancer survivorship. Leslie is also on the board of Colorado Fertility Advocates. And also joined on our panelists, we have Kristin, Mead, Moody. With a background in healthcare and billing management, Kristin helps fertility patients navigate insurance and the cost of fertility care as a financial counselor at Shady Grove Fertility. And now I'll let our moderator take it away. Thank you so much, Trish.
Thank you so much, Ellen. I'm so excited to be here. As mentioned, I came from a medical research background and got into a lot of policy along the way. And this topic has become really interesting and passionate for me because I do have a dear friend, actually several, as it turns out, who are struggling with understanding the nuance of the laws that have gone into effect and how this is working. They were really hoping they would have coverage, as I'm sure so many of you are experiencing. And so I invite you to join us today and continue learning with our experts and the journey that we are all on here to figure out how we can get full coverage for these critical procedures. So without further ado, let me just outline for you. So we have topics covering everything from the history of how we got to where we are here in Colorado, some federal topics coming in, what we could possibly do moving forward in Colorado while we await any federal options. We are also going to have discussions on what that currently means for coverage in Colorado specifically, and how patients can access those kinds of topics, and then what some of the research might be coming on down the line and various types of alternatives. So without further ado, let me turn this over to Betsy, who's going to give us a fantastic rundown of the history. One small thing, if you have any questions along the way, please feel free to enter them in the chat box, and we will try to do our best to address either in writing or on video as possible and time allows. So Betsy?
Thank you. And I believe I need to share my screen, so bear with me while I do that. And I want to confirm that it can be seen. Thumbs up, nodding, I see. Okay, I'm gonna go to the beginning here. All right, and everyone is still good and can still see my screen. Wonderful.
Sure.
Well, thank you again, Trish, and everyone at Colorado Fertility Advocates for hosting this important webinar. Resolve was honored to partner with CFA on the Colorado Buildings Family Act and other pro-family legislation in Colorado. So let's go back to 2020 when the Colorado Building Families Act was signed into law by Governor Polis on April 1st, 2020. April Fool's Day, which now seems a little auspicious, but the bill was championed by Representatives Carrie Tipper and Leslie Herod and Senators Faith Winter and Stephen Fenberg, and was based on Resolve's model legislation to provide insurance coverage for infertility treatments, including IVF, and specifically at least 3 completed egg retrievals and unlimited embryo transfers, as well as medically necessary fertility preservation for cancer patients and others at risk of medically induced infertility. The legislation was written to cover everyone in the individual, small, and large group insurance markets, which is about 1.2 million people in Colorado. So as our bill was entering the final stretch in the Senate, we all learned about a new disease called COVID. And our bill was actually one of the last bills that passed before the government shut down. But also during this time, as our bill was moving in the Senate, the Trump administration had proposed stricter rules regarding the Affordable Care Act, or ACA, and reporting requirements by the states about new mandates. As a result, the Polis administration added language about the ACA and defrayal to our bill. Defrayal means the state would be required to pay for the cost of the new benefit. The added provision asked for interpretation from the federal government's Department of Health and Human Services about whether the new coverage exceeded the essential health benefits, which include pregnancy and maternity care. The Colorado Division of Insurance argued that it was merely an update to maternity care, but HHS under Trump shared their opinion that it was a new mandate and they thought the state could be subject to defrayal. As a result, the portion of the bill covering the ACA marketplace plans, namely the individual and small group markets, would no longer go into effect. Only the large group market would go into effect in 2022. But then as 2022 neared, the insurers argued that where the language appeared in the bill meant that the entire bill could not go into effect. Given this legal uncertainty, a fix-it bill was introduced to clarify the coverage. That coverage was required in the large group market. The implementation of fertility coverage legislation was signed by the governor in April 2022, but the effective date was moved to a year later in 2023. So plans in the large group market that renewed in January 2023 or that will renew later in 2023 are required to provide the coverage passed in the Building Families Act. And for individual and small group policies, it was spelled out that coverage would only be added 12 months after HHS determines that coverage for fertility services does not require defrayal by the state. So what does all this mean? You're asking, am I covered by the new law? So to find out, you should ask HR, Human Resources at your employer, the following questions. Number one, is my employer fully insured or self-insured? Self-insured employers usually have 500 or more employees, and self-insured employers are not governed by state law, but can voluntarily provide coverage, which I'll talk about more later. Number two, is my employer's health insurance controlled by Colorado? And my understanding is on your insurance card, there should be some sort of Colorado logo if that's the case. But if your employer has headquarters in another state, insurance might be controlled by the state's laws, that state's laws. So ask HR to confirm where the insurance is drawn from. And number three, is my employer part of the large group market, which is defined in Colorado as more than 100 employees. If your employer is fully insured with insurance controlled by Colorado and has more than 100 employees, then you are covered for IVF and fertility preservation when your plan renews in 2023. So some plans have already renewed in January, but some may not renew until June 2023 or perhaps another month. So what exactly is covered? The law specifies coverage for IVF, including what I mentioned before, a minimum of 3 completed egg retrievals and unlimited embryo transfers, and coverage for fertility preservation treatments for those at risk of medically induced infertility. And this includes freezing sperm, eggs, and embryos before those potentially sterilizing medical procedures. Also, coverage is inclusive of the LGBTQ+ community and unpartnered individuals, as well as carriers of genetic diseases who need IVF with genetic testing in order not to pass on the disease. Resolve has a video on our website that goes over what I just shared about coverage, and you can also share this with your HR folks to make sure they understand what's required. And I don't believe we have time to play it, so please do visit the website. So now some of you may be disappointed to realize that you are not covered by the new law. So what can you do if you're not covered? A couple of things. please take a look at the plans offered on Colorado's ACA marketplace called Connect for Health Colorado. Under Colorado's current benchmark plan, diagnosis and treatment of infertility, including artificial insemination, is covered. IVF is not covered, but diagnosis and some treatment is. But be sure to check the plans carefully to confirm that the coverage details, exactly what the coverage details are before enrolling. And it's important to remember that any employer can voluntarily add fertility benefits. We are already seeing in Colorado that employers not bound by the state, by the new law, are adding these benefits to stay competitive with those employers that are required by law to provide fertility benefits. University of Colorado is a great example, and it started with employees making the ask. And we see time and time again that even one employee making the ask makes a difference. And Resolve will support you every step of the way with a toolkit, templates, and private coaching at resolve.org/coverage at work. And I believe CFA has done a webinar on coverage at work, so it's probably in their archives as well, but reach out anytime about that. Resolve is also working at the federal level to address ACA defrayal concerns. Colorado is not the only state to express these concerns and to limit coverage to the large group market. Some of you may have participated in Resolve's Federal Advocacy Day, where Colorado advocates asked for help on this issue in their meetings with their lawmakers. Well, Senators Hickenlooper and Bennett heard you, and they worked with Resolve to write a letter last month to CMS, which oversees the ACA, to urge them to affirm that IVF and assisted reproduction services should be classified as an essential health benefit under pregnancy, maternity, and newborn care. This is an important step, but I don't have to say that anything with the federal government takes time. I do want to add, for any federal employees living in Colorado, that Resolve has also been working with the Office of Personnel Management and directly with federal employees through our Coverage at Work program to get fertility benefits added to the Federal Employee Health Benefits Program. Medically necessary fertility preservation is now required in all federal employee health plans, and IVF will be covered in a handful of plans in 2024. And we are continuing to work to expand the coverage so all federal employees can benefit from it. So on that note, I'll provide my contact information, and I think we might have time for a question or two now or later. And let me stop sharing my screen to facilitate that. So
thank you so much, Betsy. That is incredibly helpful and a great overview of the comprehensive look at where we've come in Colorado, what's going on at the federal level. And we are going to get more into what is covered and all of that with other panelists and experts, but I do want to pause for 1 second. So it sounds like both of Colorado's U.S. senators are now informed and supportive of this issue. Is that accurate?
Yes, that is true.
Fantastic. And so, as you mentioned, those efforts can take a lot of time at that federal level. And certainly there are many more people who have to be on board for things to sort of happen further. So I think the follow-up question that I have for you, and one that we've been sort of asking around locally, is if federal action can take some time, is there something that in the interim, Colorado's governor, legislature, the DOI commissioner, any of these folks could seek to take action in some way to help Coloradans in the meanwhile try to gain faster coverage? And I know you did mention that Polis passed the bill, but there were some clauses that were added. what's the status there and what does that look like?
Right. Well, great question. And since you mentioned the bill and the provision about the ACA that was added, one option is to introduce and pass a new bill to cover the individual and small group markets without any caveats, and to go ahead and budget in the event of defrayal. Other states have not been required to defray, but if defrayal is still a concern, then the state could budget for it in case it happens. And honestly, the state budget should reflect the state's values. And twice now, we've passed legislation to try to help families overcome cost as a barrier to care. So, setting aside the funds in case defrayal is required, should reinforce that priority. And again, our experience is that no state has been required to defray. Another option, and something that I believe the Division of Insurance did do in the past, was explore adding IVF coverage to the state's benchmark plan. I believe they looked into this once before, but couldn't collect all the data they needed. But now there's real data in Colorado, so that is available from the new law. So perhaps that could be revisited. And I would also hope that conversations with the Department of HHS in the new administration could also be continued to see if perhaps there's a different outcome.
Yeah. And actually, I'm so glad you mentioned the data part, because I have looked at some of the numbers, and the numbers that I've been able to find show that even if defrayal costs were to be included, which again, as you stated, other states have not yet been required to do, that even if that came to be, it's actually an extremely small amount of money in the larger scheme of Colorado's budget. I think it's a few dozen million, right? So like 30, 34 million max is kind of what I've been finding. And it could be as little as zero. So,
wow. Yeah.
So with that, in the grand scheme of Colorado's budget, that's incredibly minuscule. So does that kind of track with
yes.
what you've seen?
Absolutely. We have seen in other states that adding this coverage costs as less than 1% of the total premium. And that's not even factoring in the cost savings from a reduction in multiple births. So, that's where the zero could come in, where, savings offset any premium increases. But, the private sector, these self-insured companies are continuing to lead the way, adding coverage. And we surveyed them with Mercer, and virtually all employers said that adding IVF benefits did not significantly impact their medical costs. So I think the state would definitely have the same experience.
Great. Yeah, and I want to make sure we can move on to our next panelist, but I have one last question. So it sounds like there are some Colorado options that could happen here in the meantime of federal action, in which case, anyone on this call, what are some things that they can do to help advocate to make that possible?
Well, definitely stay in touch with Colorado Fertility Advocates, because anything that is done in Colorado will be in partnership with them. Resolve also has the Resolve Advocacy Network, so you can find out what is happening in your state and also at the federal level. So I would say just stay in touch with both our organizations to get involved and know that it's your stories that make the difference. Your voices are the most important. It's not Resolve, it's not CFA, it's not a lobbyist, it's actually the patients and the professionals who are providing the care.
Yes, and actually several, I've had over a dozen folks that I've been able to interview so that we can start sharing those stories with some of the local politicians and folks who are representing us. So, again, you can contact those folks directly too. So thank you so much. That's incredibly helpful. Stay with us. We might have some more questions for you. But
Absolutely.
Meanwhile, I would love to turn the microphone over to Kristin, who can talk with us about more details on how patients are covered under the new law, procedures, options, and general patient frequently asked questions that come up. Can you go ahead and sort of give us some overview there, Kristin?
Sure. Honestly, the very biggest question that we get is just how do we know if we're affected by that, if we're covered under the Colorado Building Families Act? And, our very first suggestion to patients is that they contact their employer. Some patients don't feel comfortable approaching their HR about coverages and stuff like that. So in the event that they're not either comfortable or they're not finding the information that they need, I do sometimes also suggest that they contact their insurance company. They can ask if their employer group is fully funded, or usually that is kind of a backdoor way of finding out whether or not this coverage applies to them. It's a great step in the right direction. We would love to see the small market and the self-funded or the self-funded plans, add that coverage as well. But that's really what we're seeing at this point is just, the biggest question is does it affect me? Do I fall underneath that?
Sure. And I think Betsy also spoke to some of those questions that can be asked, but I love the idea that you're saying, if you're not comfortable asking your employer directly, you have another option by also going straight to your insurer or possibly some other advocacy routes.
Right.
And I think the follow-up question that I have there is, what if someone finds out I'm not covered, I need help covering this? How do patients manage this? I've heard some very extreme stories so far.
Yeah.
And I'm curious, from your expert position, what do you recommend? How do people best approach that?
It is difficult. The cost of going through infertility treatment is very expensive. And, there are certain offices that do give self-pay discounts there. You can look into military discounts. You can look into whether or not you have a certain earning per year if you qualify for help that direction. There are grants that you can look for. So there's not a huge amount other than, the self-pay option, which is difficult for some people. But, it's definitely worth looking into and seeing, where you can find any little reduction in cost.
Yeah. And other than Resolve, of course, which is a fantastic resource, and I highly encourage everyone to check out what they have listed. Are there any specific grants or things that come to mind that patients might want to know, or people in this space on our call might want to know?
I probably don't have a whole lot of grant information. There are things for the patients who have cancer diagnosis where treatment of that condition would most likely cause infertility. There are grants out there for those. There's a very small amount of grants for just infertility coverage, but it's definitely worth looking into. And again, a lot of places offer military discounts or income-based discounts. It's always a good idea to ask.
Asking is always a great idea. Yeah.
And of course, And, again, when I said, the first thing I tell patients is to check with their employer. We also use the link to Resolve. We send the link, to our patients for Resolve so that they, it's the biggest thing with whether it's infertility coverage or even medical coverage is, we're reaching that point now where we want patients to create a level of awareness of what their benefits are, and kind of the knowledge is power mindset. And the more that they can research and find out what is and what isn't covered and, what their options are, that allows them to make the best decision for their family.
Yeah, that makes a lot of sense. One of the things that I wanted to sort of ask on behalf of those who I've interviewed is that many folks have asked the question, there have been discussions about how in about 2017, I think it was, that the American Medical Association actually defined infertility as a disease, and that matches the World Health Organization designation of that. And I think the question sort of becomes, so if we've identified this as a disease, how does that impact our financial coverage? Like, shouldn't this be covered? And I think that's part of what we're all sort of arguing here. But But does that designation by the AMA, does that change anything, or is it strictly laws?
I think at this point, it does not. It's strictly laws. You know, the shift of infertility coverage is happening in Colorado. It just seems to be a little slower than some. You know, we see more infertility coverage from like East Coast employer groups. I think it's there. It's just, you know, trying to get the forward motion of increasing coverage.
Yeah, and actually, I'm going to go to a question that we have in the chat. And the question is, have you seen that there are more people in Colorado that are utilizing fertility treatments now that legislation has passed, at least in part of the goals, compared to people out of state using those services? And how much economic impact is that having in the state at all? Are you familiar with seeing any of those changes yet?
You know, I don't know that I would necessarily have information on other states. I can tell you that purely based on the increase of coverage, even in the employer groups that don't necessarily fall under like CU and UC Health, you know, I think the utilization is higher because that benefit is now there. But I would probably not be the right person to ask about data from a different state.
Yeah, well, and I think in the interviews that I've done in the close friends, I think everyone has said we're doing it because we have to, not because we want to. So I think whenever the question for me comes up of, is there an increase in use? I think that's something to keep in mind. This is not something that if given the opportunity, people would rather not have to do this.
Oh, completely. Well, and I think too, that doesn't mean that they're not doing it. They're just utilizing their benefits. So even patients who maybe, you know, prior to them having the benefit, they would have had to have figured out how to self-pay for those services. So it doesn't necessarily, one doesn't necessarily lend itself to the other, but the fact that they have coverage is just now, they're not having to put themselves in a financial situation, you know, because they don't have any coverage.
It's an equity issue, really,
Right.
at the end of the day, because you have people who can afford to do that maybe, and the vast majority of people, unfortunately, probably can't. And so I think, I don't know that we have full data yet in Colorado on some of those changes and increase. It's a great question, but it sounds like you're seeing maybe some small increase a little bit here in Colorado.
Right.
Well, thank you so much. I really appreciate your perspective. And I want to move on and stay with us as well, because we might have some more questions for you. But I'd like to move now to Dr. Appiah, who I'm so excited can join us today and share the medical perspective, particularly within pediatrics and oncology. And I think that's just a really fantastic direction that we can start turning this conversation in. So Dr. Appiah, can you greet everyone and let us know where you're coming from?
Yes, I'd be happy to. Thank you. I have one question. Is it okay if I do share my screen just to make it easier for the participants? And I think Ellen may.
Ellen can, I think, do that. Yep.
Okay, yeah. And while she's giving me access, so again, I'm Leslia Appiah. I am the Division Chief of Academic Specialists in Obstetrics and Gynecology at the University of Colorado. I am fellowship trained in pediatric and adolescent gynecology, and I am the director of the Fertility Preservation Program. And I joined the institution in, see here, and slideshow. I joined the institution January 2019. I think you're going to see my notes, but that's okay. There are none. And when I joined, part of the reason I joined was to help build the fertility preservation program here at the University of Colorado. And this is a passion of mine. And so I was very excited to join CFA and really participate in the building of this legislation and writing in legislation that spoke directly to fertility preservation. I think in general, we speak a lot about infertility for individuals who have tried to conceive and have not been able to, but fertility preservation for individuals who are at risk of infertility from cancer treatments has also been a real issue. And so we were able to help put that speech into the legislation. So just to give you a little bit of background, so prior to 2019, so before the Colorado Building Families Act really came into fruition, we had challenges with fertility preservation in children in terms of how they compared to adults. So egg freezing, embryo freezing, those sorts of fertility preservation services were available to adult patients and not necessarily available to children. And in particular, because children cannot pursue egg freezing, so young girls cannot pursue egg freezing and boys at times cannot pursue sperm banking, we have very specific procedures that are available. So freezing of an ovary or freezing of testis is an option for prepubertal children. However, that option is expensive. So in order to provide fertility preservation services to prepubertal children, that is not covered by insurance. And so it was difficult really to provide them with options. And so prior to 2019, there was a ban on pursuing tissue freezing of the ovary in girls. And that ban was lifted December 2019. At that point, we were able to put this procedure through the insurance providers to allow this option for young girls. This was a bundle procedure that we combined with other procedures. So patients who have cancer diagnoses will receive a port placement or a central line placement for their chemotherapy. So during that same procedure, we bundled ovarian tissue cryopreservation procedures. However, patients still had to pay out-of-pocket costs for egg and sperm banking if they were post-pubertal. For our young adult patients, we relied on philanthropy before the Colorado Building Families Act, and specifically we used a philanthropic organization called Chick Mission, and they were able to provide funding for egg and embryo freezing in our young adult populations. So with the lifting of the ban on ovarian tissue cryopreservation by the American Society of Reproductive Medicine and the American Society of Clinical Oncology, we were able to provide that service for prepubertal girls. And that is now considered standard of care. So even aside from the Colorado Building Families Act, we're able to freeze ovarian tissue for girls because it is considered a standard of care procedure. Lifting of this ban, however, did not change coverage for other fertility procedures in children. So sperm banking, egg freezing in young girls. And also in our young boys, we have a procedure called testicular tissue freezing, and lifting of the ban did not cover that for boys as well. So with the passing of the Colorado Building Families Act, now, as Betsy described, children who have commercial insurance under their parents can pursue egg freezing and sperm banking and be covered. Our boys who are post-pubertal can also undergo a procedure where we actually take a biopsy of the tissue, that's called testicular tissue cryopreservation, and freeze the sperm that we are able to extract from that tissue. As we stated, though, Medicaid does not provide this coverage, and 40% of children in Colorado are on Medicaid, and therefore they do not fall under coverage by the law. So many of our patients who we provide fertility preservation counseling for cannot pursue sperm banking under the law, cannot pursue egg freezing under the law. They can pursue testicular biopsy because that is considered a standard procedure irrespective of infertility services. And again, freezing ovarian tissue is covered because that is considered a standard procedure irrespective of fertility preservation services. So essentially, although the law has been very beneficial for our patients who have commercial insurance, we are still struggling to provide fertility services for our patients with Medicaid, which is a significant number of a significant volume. In addition, when patients are diagnosed with a cancer diagnosis and they receive Medicaid, that Medicaid coverage actually is mandated to continue so that they can continue to have survivorship care. So we have seen that patients who are now 18 and don't necessarily need Medicaid and can be under their parents' insurance, they actually cannot transition over to commercial insurance under their parents because of their cancer diagnosis. So this is something that is new to us, and we're really trying to understand why we can't transition those patients. But there seems to be some sort of coverage under Medicaid that is more beneficial to them, and that they're actually mandated. Medicaid cannot drop the patient, I think is what that coverage is. So when we see a patient, just to go a little bit over their process, if a patient is identified to be at risk of infertility, we will counsel the patient about that risk and offer fertility preservation services. So if we have a 15-year-old girl who has Ewing sarcoma and is going to receive gonatotoxic agents, then we would offer egg freezing to that patient prior to chemotherapy. If the patient is covered under commercial insurance, then she can proceed. If the patient has Medicaid, then she can't proceed. And so we are left with crowdfunding, GoFundMe accounts, or looking to family members for coverage. Typically, we will submit the procedure to a commercial insurance if they have commercial insurance, and then provide information to the patient regarding copays and deductibles. And then if the patient has coverage, then we can proceed with ovarian tissue freezing, or we can send them to our colleagues in the community for egg freezing. We cannot submit any investigational procedures to the insurance providers, and that is a big concern because many of our patients are prepubertal and there are no standard of care procedures for prepubertal kids. And so we have to rely on investigational procedures. So in boys, taking a biopsy of the testes to freeze that tissue is considered investigational. And so although a testicular biopsy in and of itself is not an investigational procedure, because we are going to use the tissue for fertility preservation, and because that fertility preservation option is investigational, we cannot submit this through insurance. So we have many, many young boys who are going to be rendered infertile from their cancer treatments, and we can't offer any fertility preservation to them because of the investigational nature. Again, as I kind of clumsily described before, for girls, freezing ovarian tissue is considered standard of care. So our young girls do have the full spectrum of options, but our young boys still are challenged in terms of fertility. And that can be very devastating for parents when we can't preserve fertility for their boys. And I think that's what I covered in that last bullet point. So essentially in the pediatric and adolescent population, the Colorado Building and Families Act has been great for our commercially insured patients, and we're able to proceed. For our Medicaid patients, so 40% of our population, we can't proceed with any of the standard of care procedures for them. So yeah, that's kind of where we are with things. And so looking forward to hearing what the legislature does with the new request to include this under maternity and pregnancy care, and whether or not that'll be extended to children. I wonder if we have to actually impress upon them that would be a consideration.
Interesting. Thank you so much. That's a fascinating addition to this conversation. And I do have a couple of questions, and I'm also curious if Betsy might have some thoughts from the policy side on whether or not these conversations are happening. But before we get to that and the other questions, I am wondering In terms of fertility preservation, is there pending research that shows that there might be any change or upcoming ways that people should be aware of that might provide more options in the future, or is that not something?
Yeah, no, that's a great question. Yeah, so this population lends itself very well to research. So there are research trials that are underway currently to try to remove gametes, so remove immature eggs from ovarian tissue and mature that in the lab so that we don't have to remove an ovary from a young girl. We typically only go to such drastic measures if the patient is at the highest risk of infertility. But even in those situations, if we could just remove the eggs directly from the ovary, that would be ideal. Many patients, children or adults, don't necessarily have time for stimulation, the 12 days that it takes to undergo stimulation to retrieve an egg. So ideally for those patients, so patients with leukemia or lymphoma that includes a mediastinal mass and they have to really go to therapy, we really need to get to the place where we are removing immature follicles and maturing them in the lab with a technique called in vitro maturation. And until that becomes standard of care, we will never be able to submit it through insurance. So once we begin to see live births from that procedure, then we'll be able to include that as a clinical care procedure. For the boys, there is research underway where we will remove spermatogonial stem cell or spermatogonial cells, so the precursors to sperm, and mature those in the lab. And so that is also the technology that we're looking forward to so that we don't have to remove a portion of the testes and freeze it. The research that is underway now by Kyle Orwig's lab is to remove a part of the testis, freeze that tissue, and then when the patient is ready to conceive or even late puberty, transplanting that tissue back into the scrotal sac and allowing spermatogenesis to occur, or even kind of taking those cells and maturing them in the lab. So those are the investigational procedures that are underway, and we won't need to see hundreds and hundreds of births before we make that standard of care. We really only need one birth from any of those technologies, and then we can push for that to become clinical care based on the coverage that we have written into the bill saying this is a fertility sparing procedure. And so then we'll be able to include that coverage for patients.
Wow, that's really fascinating. Thank you so much for sharing your expertise. One thing I do want to add, as I have been in medical research for a long time, for those who are interested in possibly finding one of these studies to maybe even participate in or at least learn more, clinicaltrials.gov is your place to go. And that is where I used to send patients all the time. So just as a side note there, just in case you're interested in following up on that. We also have a question coming in for you. What is the cost to preserve tissue for boys?
Excellent. So for our post-pubertal boys, so once we know that once we anticipate the sperm is present, so age 11, between 10 or stage 2 to 3, we presume the sperm is present. That procedure is covered by insurance because it is a testicular biopsy in a patient that should have sperm present. So we submit that through the insurance, the patient pays a copay or deductible. We perform a biopsy. Our colleagues at the IVF centers will look for sperm and then we'll freeze the sperm. The freezing of the sperm is where we're going to get into coverage by the law because that historically has not been covered. So that now should be covered in a patient who is post-pubertal. Pre-pubertal, we don't anticipate that there is sperm there just based on pubertal development. So there is no proven benefit there. So that is investigational. So that has to be covered out of pocket by the patient. Again, we try to bundle that with another procedure. So port placement And when we do that, then we can just carve out the 20 minutes that it takes to perform that biopsy and charge the patient for the 20-minute procedure, which is about $2,500. So the patient would pay for that. If we do not have the opportunity to combine that procedure with another procedure, then it's $12,000. And that's out of pocket. It cannot be submitted to insurance. And so we recently have had this battle because the cost has gone up at our institution. So now we are faced with not being able to offer this opportunity to patients if we don't see them early enough to combine it with a port placement. And so everything we do with children or in the cancer realm is urgent. Like as soon as the oncologist anticipates a patient has a cancer diagnosis, we need to be called because we need to be able to coordinate this. It is tragic to lose an opportunity to charge a patient $2,500 versus $12,000, which essentially means they can't pursue it. Right? No, $12,000 for an investigational procedure is not fair. And so, or ethical really. And so we really need to see the patients as soon as possible because all of these patients are getting a port, a central line. They're all undergoing some sort of procedure. And so we could combine it with that procedure if we're notified early enough. And then the families can usually come up with the $2,500. We then currently ship the tissue to Pittsburgh, University of Pittsburgh Medical Center, where they process and freeze the tissue. So it's $500 for the flight and $500 for them to process the tissue. So $3,500 out of pocket for this procedure in boys, for prepubertal boys, if we can combine it with another procedure.
And that out-of-pocket expense, would that go toward one's maximum out-of-pocket annually?
No, it can't even pretend to be
Nothing.
associated with insurance. So now if they have an HSA, maybe that's a different conversation that we've not kind of pursued. But no, we cannot include it at all.
I was afraid you might say that.
Yeah.
I have several really great questions coming in. So what I'd like to do is, now that you've all had a chance to share some of our primary points that we wanted to discuss, I want to turn to the chat questions. And I'm going to read one of the questions, and whoever might like to respond, feel free to sort of jump in. I think there are actually a few different aspects to each, and there are at least 3 or 4 here. So let's start with the first one. The first one is, how much does insurance typically cover for IVF or artificial insemination? This person thinks that they might be covered and will look into it more, but what qualifications are required to be eligible and be considered infertile? Would one of our panelists like to help us answer that?
Give you a little bit of information. So usually what we'll do is, and this is again, stressing the fact that I said, what's primarily important is for patients to learn what their benefits are. But we usually start out with a patient by checking their benefits and seeing at what level the coverage is. It's really determinant upon the employer group and the plan that they have. There are some plans that require patients to attempt IUI first before they'll pay for IVF. If they have a deductible, the deductible is going to apply first and then the co-insurance subsequently. Some plans, will restrict the number of IVF cycles. So it really kind of runs, the gamut as far as I've seen, coverage that's 50%, but then I've also seen 100% coverage of IVF. So it really is determinant upon the employer group and the plan that they have, but that's usually something that can be identified and get pretty close to what the patient's responsibility is prior to their cycle start date.
That tracks pretty closely with what I'm hearing from a lot of the interviews that we've been doing from the journalism side as well. It can really vary, especially when it comes to medicines and how much those end up costing as well. To the second point of this question, would anyone like to address what qualifications are required to be eligible to be considered infertile within this law structure?
I can address that for the law, and then certainly Dr. Appiah can add anything medical, but the infertility actually is defined in 3 ways in our in the law in order for it to be inclusive and comprehensive. The first bucket is the ASRM definition of trying to get pregnant for 12 months of unprotected intercourse for people under the age of 35, and then for 6 months if you're over 35. So that's sort of the heteronormative definition of infertility. And then the second bucket is if you are, or your with or without a partner, you require medical intervention. So obviously a same-sex couple is not going to have all the gametes needed. An unpartnered individual won't have all the gametes needed. So basically the second piece of the definition is if you need medical intervention in order to reproduce with or without a partner. And then the third one gives the doctor some autonomy to determine if someone shouldn't wait 6 or 12 months, or there's some other reason. I mentioned carriers of genetic diseases. So then there's the as determined by a physician based on diagnostic testing and key findings. So
right. And then to add to the fertility preservation, those patients who are at risk of infertility from a diagnosis or from planned therapies. So someone with Turner mosaicism is at risk of infertility, so that patient should be covered. Someone who's going to receive chemotherapy is at risk, so they should be covered.
Yeah. Okay, great. The second question that we have is, how are the facilities that provide IVF services working with employers that fall under the Building Families Act and getting in network for the services? And this comes with the explanation here that Denver Health Medical Plan is providing infertility services under this law. However, none of the Denver metro facilities are accepting their insurance. So how does someone resolve this issue? Thank you. It's a great question.
I'll step in on this one too. So it's my understanding that the Denver Health Medical Plan does not currently have reproductive endocrinologists within their program. It is difficult. I know I can only speak specifically for Shady Grove, but we are attempting to, work or do a kind of a workaround for that. But it's really, I would encourage patients who have Denver Health Medical Plan to continue to have that conversation with the plan or somebody in the HR to kind of light a fire under it, to see if they can come up with some kind of either single case agreement or, just identifying a way. They can also technically pay out of pocket and then seek reimbursement from Denver Health Medical Plan. But again, that's not always an option, and it's very cost restrictive. It's restrictive to patients who don't have that kind of funding to pay for something upfront and then seek reimbursement from their plan. But I would encourage a patient to, like I said, keep having that conversation and, just they have the benefit, so they should provide somebody who they can seek that treatment from.
And the follow-up question here that we're getting in the chat is Denver Health self-insured, and is that the issue?
They are self-insured. However, they've still provided the benefit.
Right.
So again, it's kind of a sticking point, obviously, because they're providing the benefit. And I believe that they started that on 1/1, but again, it's my understanding that Denver Health does not have any reproductive endocrinologists within their network. So it's just taking, until something can be done contractually, they need to push for a single case agreement.
Okay.
But it sounds like, Kristin and Trish, maybe I also misunderstood the question. It sounds as though the person asking the question is concerned that the IVF centers are then not accepting Denver Health.
I can I can only speak for a recent patient that we've had that I'm still currently working on.
Mhm.
We don't have a contract with Denver Health, but we're willing to work on a single case agreement. With this particular patient, it seems to be stuck on the Denver Health side, which is why I'm encouraging the patient to go back to their benefits administrator and kind of push for that. So it can be done. It takes a little bit of time and some hoops to jump through, but it's just, you have to sometimes be your own advocate. And
well, and actually, not to interrupt, but is this possibly one of those situations where working with a patient advocate can actually be the right approach? And for those who might not be familiar with a patient advocate, there are folks, some of the services are free, some are for cost. It sort of depends on the person and how things work out, but those are people who can fight for either reimbursement or coverage for a patient. And there are services, I know several patient advocates even in Colorado. So I don't know, is that something that someone could perhaps look into to try to assist with that?
I would recommend that patients use whatever resource they can get. I mean, there's, like I said, there's times when they'll just, whatever they can find, whatever information that they can provide. It's, unfortunately, sometimes it does fall back to, it's just a matter of getting the right people on the right page and making something happen. And you hate to say it, but sometimes squeaky wheel gets the grease. And I don't mean it in a negative manner, but you do have to be a proponent for yourself and your own advocate. And if you have the benefit, then you really need to, press for somebody to make that decision, as far as, being able to provide the treatment.
And Trish, can I weigh in on that too? So
Yeah.
on the fertility side, we do have patient navigators to help because, these patients don't have the energy, right? They have cancer. They don't have the energy to go back and forth with the insurance providers, and they don't have time. And so we do have patient navigators for these patients to assist with this. And to answer Daniel Major's question about if a Medicaid patient tries to pay out of pocket, will they potentially lose their Medicaid benefits? And that is a risk. We have had the Medicaid deny a patient paying out of pocket for fertility services because I think their kind of premise is if you can pay for that, then you can pay for your medical care. And so that is a risk, Dan. Yes.
Okay. Yeah. Thank you for answering that next question. We do have a couple more questions. And so I just want to pause for one moment. We are happy to answer those questions. We have committed to going a few minutes over if needed, which we are. For those of you who are unable to stay on the call, please be reminded that this is actually being recorded. So you can always go back to that website and visit and fast forward into the video where you were able to leave off. So we will actually answer the remainder of questions. So if anyone has any final ones, Ellen, is there anything else that I should add before we jump back into the last couple questions?
No, that sounds great. Let's go a few more minutes to get a few more questions answered. Perfect.
Thank you so much. And so I think wrapping up on this Denver Health issue, another follow-up that we're getting here is, so does that mean that the fertility clinic must have a contract with the insurance company to provide covered fertility services? Is that what you're saying?
It is. So Denver Health, because they're self-funded, they're their own insurance company. So they pay all the claims themselves rather than like a fully funded plan is somebody who pays an insurance premium. And then, the health plan is at risk. With the self-funded, it's their own plan. And so, yes, technically, anybody who's within that Denver Health network requires a contract for patients to be able to see them at that in-network rate and have it covered. I've done, where the patient, I did have a Denver Health patient who paid out of pocket, who was able to pay out of pocket and seek reimbursement, but that's not typical. And that's not a reasonable solution. So yes, we would have to have some kind of contractual agreement between the fertility clinic and Denver Health. And that, like I said, it just is a matter of getting the same, people on the same page.
Okay, well, thank you so much for clarifying that. I can imagine it's not fun to try to, I've had to
It's frustrating.
insurance and it's not
Yeah.
fun. And so this is an extra hoop. So I think, thank you for sort of helping to at least start that process of what that might look like. And it sounds like clinics can also be part of that process as well.
Yeah.
Trish, can I ask a clarifying question of Betsy? So Betsy, just to clarify, patients don't have to wait till open enrollment to select the benefit, right? The benefit should be there, but they should use open enrollment or really any time as an opportunity to verify. Is that right?
Well, if I'm interpreting correctly, so a number of plans that renewed in January 2023, if they are fit the description of having to follow the law, then everyone who enrolls in that plan, it's automatic. Those benefits should be there.
Okay.
Not my understanding, and correct me if I'm wrong, Coloradans, is that some plans renew in January, but other plans renew in June. So it's possible that people's plans that renew in June, they currently don't have the coverage, but come June, when they re-enroll or renew, it will be there.
I do want to add to this point, something that I've been finding in the interviews that we've been doing is that even though you would think that the people who should know about this law on the health insurance side would know about it, many of them do not. So a lot of patients I'm hearing are actually still getting charged for things, and it turns out that they should not have been charged. And so that is something that I'm starting to hear as we are shifting further into this year. And so I think I just want to put that radar that on your radar, that if you are being charged for something that you think should be covered under this bill, feel free to follow up, because we are finding that not everyone is fully informed yet on what coverage looks like in Colorado under this new bill.
Yeah, and what I've been doing when I see my patients is I put the link to that wonderful video and the Resolve site in their after visit summary. And I tell them to go to that link, watch the video, look at the questions so that they can then speak intelligently to their insurance provider. So I'm giving the patients the link to that site.
Fantastic. We have a couple more questions, so let's go ahead with the next one. We do have time. Could you tell me the difference between if a person is 35 and younger or older than 35? Thank you. Wonderful meeting. So thank you so much. And if you have more questions, please put them in the chat now. We will be wrapping up shortly.
I'm the one who said it first, but again, Dr. Appiah, please. So the traditional medical definition of infertility is not being able to get pregnant or stay pregnant after 12 months of regular unprotected intercourse if you're under the age of 35, and if you're 35 or older, then it's 6 months. But a physician can there can be earlier medical intervention if the physician deems so. So for some people, you don't have to wait the 6 or 12.
Right. And the reason for that is that for all comers, patients, 85% of patients are likely to conceive after 1 year of unprotected regular intercourse in the absence of an underlying medical condition, and then 90% in 2 years. So the definition is based on the likelihood that the majority will conceive by a year. However, as Betsy stated, if there are underlying medical conditions that are predisposed into infertility, then it doesn't make sense to make someone try for 12 months when they have endometriosis, PCOS, one fallopian tube, so different medical conditions, then we only recommend 6 months. And if you're above age 35, then you have a decreased egg count. And so again, it doesn't make sense to make a patient wait a year when we know that their fertility is waiting.
Okay. And I think the last comment that we had is actually not so much a question as a comment, but just letting folks know that some folks are actually not having open enrollment until July, it sounds like, under Kaiser. And so if you are someone who might be on, say, Kaiser or a similar plan, it might be, the change might come as late as apparently July. So just something to keep in mind. And we have one more question coming in. Is there an estimate of how many Coloradans currently have coverage through the law with large group Colorado-based plans? It seems like everyone I know is not qualifying. In that case, it might be helpful to know that number in pushing for a new law, which that makes a lot of sense. Do we have any data on that yet?
So Christina, are you suggesting that the majority of people you know don't have a large group plan, they're part of a small group plan or individual insurer? Is that what you're saying? Yes, okay.
Right. Our estimate of covered lives in the large group market is about 670,000. And that's people with the insurance. So it would be larger with the family members, I believe. That's how it's calculated. 670,000 in the large group.
Yeah, and I think it's worth noting that if I recall correctly, Colorado has a higher than average definition of how many employees rather are required for a large group definition. Is that accurate? I think most states have much lower.
I'm not sure. I think a lot of states it is 100, but I know of other states where it's 50. So but I do believe that 100 is not that unusual to be characterized as large group. And then of course, when you get to self-insured, that's about 500 or more. So it's only between 100 and 500 basically that the law is impacting. And, you know, our goal is we want everyone to get the coverage. So there's still work to be done.
Okay. I'm not sure why my video is having issue, but I am coming in on my vacation in Jackson Hole. It's a wonderful ski trip. So I am very happy to take time to do this. I think this is something that I'm so grateful. And I think our viewers are also extremely grateful for all of your expertise. So I think we have answered all the questions. If we have not, please let us know once more in the chat, but I think we've answered everything. And thank you so much. I'm going to turn it back to Ellen to do any sort of final wrap-ups and closure. But thank you again all for coming out today and take your time to inform us of where we are with the new laws.
Trish, thank you for joining us from your vacation, as well as Cassie, who's on vacation as well. We encourage further questions, further involvement. If you want to reach out, you can reach info@coloradofertilityadvocates.org, so we can try to help you get answers there. Also, the more people who want to join as members and become active, the larger we can amplify our voice and really push for these changes. I want to again remind you of those events that are coming up. So Resolve Advocacy Day on April 25th. Please register, please get involved. And then our next in-person event where we are lighting up the city and county building in orange is April 24th. So we hope to see everyone in person. Thank you again for joining us. Thank you to our moderator and to our panelists. We so appreciate you sharing your expertise and sharing this information.
Thank you so much.
Thank you for the opportunity.
Rebecca, you can stop the recording if you'd like.